Good morning, and thank you for the invitation to speak today. And we're going to switch gears, as mentioned. I'm Dan Judge. I'm a cardiologist at Medical University of South Carolina. My disclosures are shown here. I've received some payments for amyloid therapy development, and I'm going to talk a little bit about drugs that aren't yet approved, so keep that in mind. Like the other talks, we'll start with a case presentation. This is a guy that I saw not too long ago, a 72-year-old with new heart failure. Fortunately, the thought about amyloid came in the case of his LVH with a normal EF, so heart failure with preserved EF, and his EKG not showing LVH, but showing low voltage. He had elevated lambda free light chain with a ratio of 0.2, and his immunofixation of the serum showed a monoclonal IgG lambda protein. His technetium pyrophosphate was grade 3 with a heart to contralateral ratio of 1.65. And like always with a PYP scan, you need to do SPECT imaging, so not as this just showing up in the left side of the chest on a chest x-ray, but planar images through the heart to say it's in the muscle of the heart, not in the blood pool. So that was grade 3 positive on the Perugini scale, and his immunofixation in the urine was normal. So here are your choices. Not yet. His bone marrow. I'm not in a cardiology audience, I'm in a hematology audience. So of course we have a bone marrow exam. CD138 highlights plasma cells. They're scattered in small aggregates, less than 10%. His Congo red in the bone marrow is negative. FISH was done and showed an extra copy of chromosome 5 and no other concerning chromosomal abnormalities or mutations. What's next is the question. Here are your choices. Please provide your answers. Probably getting votes. I will, in the interest of time, move forward. Hope. And there we go. And we've got a lot of the correct answer, and I like that. The heart biopsy is the answer. TTR genetic testing falls in later, and I think based on the talk, you've probably figured out that this man has TTR amyloid. His biopsy is, of course, positive by Congo red, which tells us amyloid, but doesn't tell us which type. And then mass spectrometry, so really digging into the protein and saying what exactly is there, shows us that it's transthyretin amyloid. Well, TTR amyloid has two distinct types, the hereditary and wild type versions, and it was thought to be quite rare until we started to look more. It's hard to find wild type TTR amyloid unless you have a good imaging assay, which is definitive, like the PYP scan. And that's really been the, I think, revolution in recognizing wild type TTR amyloid. The familial form is less common, but there is certainly more out there than we're recognizing. Wild type is more common by far than hereditary. For the genetics, the nomenclature has really changed. I think one of the earlier talks mentioned V122I is now called 142I, and that's correct. The initial protein analysis that was done in the serum early in the days of amyloid, 100 years ago, we're looking at the circulating mature protein and the N-terminal cleavage of the proximal portion, the first 20 amino acids, leads to the counting of a valine at position 122 in the serum. If you look at the first methionine, taking into account the N-terminal propeptide, then that's 142I. So typically on a genetic test report, it will be called 142I. And most publications, and certainly in the past and currently, use the traditional nomenclature. So the V30M is V50M. And V122I is really something that's very common. 3.4% of African Americans have this pathogenic variant. What we don't know right now is the penetrance of this allele. Is it 50%? That's probably the highest that people will take into account. Or other studies suggest that it's something more like 10% of people who carry this pathogenic variant at some point in their life, usually later, like 70 years of age on average, will develop amyloid. The red flags are shown here. Frailty, you know it when you see it, but it's not always there. Carpal tunnel, particularly bilateral carpal tunnel syndrome, should be raising red flags. Peripheral neuropathy, is common with TTR amyloid. Even wild-type TTR amyloid, although that's debatable. Sometimes people say that wild-type is restricted to the heart. One of my colleagues, a neurologist, is convinced and has shown good data that it's present in the nerves. Hypotension, particularly people who've been on multiple medications for high blood pressure for years, and now they're stopping it and they're developing hypotension without meds, clearly raises the question of autonomic dysfunction or cardiac amyloid as well. Change in voice. A lot of my patients tell me that their voice has gotten deeper and raspy, and their spouses will tell you that, and it's often because amyloid is there in the vocal cords. I like this biceps tendon rupture that Rodney Falk recognized among his patients. He looked at about 100 of them, and showed that a third of them had biceps tendon rupture, so the balling up of the biceps tendon, which is often not recognized by the patients. So the diagnostic algorithm, I hope this goes through some of the points that you're already aware of. The first part of this is suspicion. You need to know or think about amyloid. And then the first, at least in my approach to amyloid, first thing to do is to look for serum and urine electrophoresis with immunofixation. Has to have immunofixation, as well as a serum-free light chain assay. If there's evidence of a monoclonal gammopathy, I'd like to change what we say with MGUS from monoclonal gammopathy of uncertain significance to must get under the skin. If you have a monoclonal gammopathy and there's any suspicion for amyloid, you need to get tissue. So if that answer is yes, then a fat pad aspirate or biopsy or a bone marrow biopsy may be the right place, and you may find amyloid that way. If there's amyloid present, then you look at the echo or MRI, something that's suggestive of amyloid in the heart should say that there is amyloid present. But if clinical suspicion remains and there's no evidence of amyloid on an echo or an MRI, then a heart biopsy is still reasonable. If you find it in terms of amyloid, you have to confirm it and do amyloid typing. That's the mass spectrometry we've talked about. As a cardiologist, I typically go directly to heart biopsies. When I say to patients, you need a heart biopsy, that sounds quite striking. They're really shocked. They've been through things like a TAVR or a catheterization, a left heart cath and coronary angiography. Those two procedures that I just mentioned are much higher risk. Heart biopsies are done on a weekly basis for the first month after heart transplant and progressively less frequently, but outpatient procedure takes about 20 minutes. They're in the lab for about 40 minutes. It's done under local anesthesia. It's a venous approach. It's a small few pieces of tissue taken from the inside of the right ventricle. If it's a thick heart, then it's very unlikely to have complications. Conduction disease is the one place where we slow down or worry about it. If there's substantial conduction disease, then that can sometimes worry with a heart biopsy, but the rates of complications are around 1%. If the biopsy is positive, again, amyloid typing is important. If there is no monoclonal protein, that's the important part, then a nuclear scan, in the US it's a PYP scan, in Europe it's DPD or HMDP scans. If they are positive, that's defined by a grade 2 or 3 uptake, then TTR sequencing is your next step. Negative is wild type, positive is hereditary. If there's still suspicion and you don't have grade 2 or 3 uptake, then a heart biopsy is still a reasonable approach. Once you have the tissue, again, amyloid typing, it's important. When you have TTR, you need to do TTR genetic testing. So in terms of treatments for this condition, and I think this is the important part for me, at least, and the exciting part, replacing the liver used to be something that we thought was a good strategy, and now I think in the US, at least, and certainly in my practice, liver transplants are rarely, if ever, performed for familial TTR amyloid. Remember that the TTR is produced by the liver. If there's a genetic mutation and you remove that liver and put in a normal liver that doesn't have that mutation, then you only make normal protein. Normal TTR can still aggregate and deposit in places where there are amyloid deposits already. One of my patients who had an aggressive mutation and early onset disease ended up having a liver transplant after she already had some substantial cardiac involvement. When her liver transplant was done, her heart failure progressed, her amyloid progressed in her heart. She ended up later, a few years later, having a heart transplant. And the pathologists who looked at her heart transplant were able to recognize that there was pathologic amyloid, meaning pathologic TTR protein initially, that was subsequently added to by only wild type deposition, meaning the liver that was put in still produced TTR as expected, and that TTR misfolded and deposited in her heart. Heart transplants are still certainly done, and I think heart transplants are a good strategy for those who are eligible. Stabilizing the mutant protein, turning off the gene, removing amyloid plaques from the heart or elsewhere, and removing or fixing the TTR gene are also areas that I'll talk about. I'll start with stabilizing the mutant TTR protein. And this really idea comes from a naturally occurring mutation, T119M in the traditional numbering system, a threonine at position 119 that becomes a methionine, and that actually stabilizes the TTR complex. The complex circulates as a tetramer, and if there's a V30M mutation, and at least in the example that Jeff Kelly identified in 2001 and published, showing that the other copy, a transmutation of the stabilizing mutation together with the destabilizing mutation, ended up really abrogating disease. And so that idea that if genetic complementarity can improve things, maybe pharmacologic agents can stabilize the tetramer and change the outcome. Well, this was the ATTRACT study. This was a cardiac study of patients with wild type or familial TTR cardiac amyloid. 441 patients were enrolled, which sounds like a small trial, but today, at the time, it was the hugest amyloid trial ever done. Patients were randomized by the FDA's recommendation to two different doses. The trial was not powered to discern a difference in the dose, but really to look for safety at high dose, 80 milligrams versus 20 milligrams versus placebo. So 3-2 in terms of the ratio of patients treated with tafamidis or placebo. The primary endpoint was complicated. It was a complex win ratio, essentially, all-cause mortality and frequency of hospitalizations successively. So if you were hospitalized shortly after enrollment, you still counted, and if you were hospitalized several times, it counted more than if you were hospitalized only once. And here's the primary outcome. To the left is mortality, which was sharply different, but didn't start to diverge until 18 months. Some people have made a big deal out of that, but actually that's, in my mind, not relevant because the improvements based on tafamidis versus placebo were present at the earliest time points in 6-minute walk test, so pre-specified secondary endpoints, and quality of life. The other thing to notice here is that in both arms of this study, the blue being those treated with tafamidis and pooled dosing, so the 80 and 20 were added there, versus placebo, the red. Both arms are getting worse over this study. This doesn't stop disease. Let me say that differently. It doesn't reverse disease, and it doesn't remove amyloid from the heart. So patients should be told that it'll slow down their condition. It won't fix their condition. It won't make them feel better. And unfortunately, the main toxicity is really financial toxicity. $225,000 a year, and if you're giving that for 6 months, that's one thing, but if it's for several years, it really certainly adds up. This is another drug that's coming along. I'm glad to be part of this. This is the phase 2 results of acoramidis, previously called AG10, another small molecule stabilizer of the TTR complex. In the phase 2 trial, it was short. We looked for safety, and it was, of course, safe, which led to the phase 3 trial, which is actually soon to release stage 1 results or stage A results from the phase 3. But in the phase 2, we did look at a pre-specified marker of efficacy, which was the serum TTR concentration. TTR, I forgot to mention, is prealbumin. They are the same proteins. Prealbumin has nothing to do with albumin other than it's smaller and comes off of gel electrophoresis faster. So the prealbumin levels or the TTR levels were going up with both doses, 400 and 800 milligrams of AG10. We've looked in a longer-term extension study at NT-proBNP and troponin I markers of cardiac amyloid and LV mass, and it looks remarkably stable in a small cohort of patients. So I'm very eager to see the phase 3 data, which are not yet available. What about turning off the TTR gene? Do you need TTR? And the answer is no. If you knock this out in a mouse, the mice do fine. There are 2 studies that were published back-to-back in the New England Journal of Medicine 2 years ago. Inotersen, an antisense oligo, and patisiran, an RNAi therapeutic. Both of them are effective at turning off the gene or dramatically reducing the production of TTR, somewhere around 80 to 90% reduction. And the markers here, the mNIS+7 neurology impairment scale was the primary endpoint for the study. Placebo is worse, and blue is
it's hard to measure.
treatment group, and the impairment score gets worse in placebo and either stabilizes or may get better in those treated over 18 months with silencers. It's also expensive. Both of these drugs are biologics, and so they're expensive and somewhere around $450,000 a year. And they're only approved, I should say, for hereditary TTR polyneuropathy, not cardiomyopathy. You have to have a mutation, you have to have neuropathy, and it's not approved for wild-type disease or familial amyloid cardiomyopathy. Removing TTR amyloid plaques from the heart seems like such a great idea. I really want to see this happen. I want to see it happen safely. This is a figure from a New England Journal study in 2015 in a therapy that's no longer in testing. An anti-SAP antibody, and SAP, serum amyloid protein, is present in all types of different amyloid. And the liver to the before versus the after looks so much better. It's so appealing that we can pull, hopefully, amyloid out of affected tissues. But it's technically challenging. These two drugs have been removed from active investigation, and there's concern, of course, that will activate the immune system, that will remove the amyloid but damage the heart, cause myocarditis. There's potential for toxicity. But if this works, wow, all of my patients will sign up in a minute to get these drugs or even to be in the clinical trials. So there's 3 drugs in the pipeline, and I'm eager again to see how this progresses over time. Removing or fixing the TTR gene, well, it sounds like science fiction, but it's here. CRISPR-Cas9 in humans in a small phase 2 study. This was the New England Journal just a few months ago. A small study of 6 individuals with familial TTR amyloid in New Zealand or London received CRISPR-Cas9, a single treatment that removed the TTR gene from their liver. You might say, well, why not fix it? But I already mentioned how if you put a new liver in so there's no longer any production of mutant protein, the amyloid can still progress. So the idea here is just get rid of the gene altogether. It's a single treatment. We don't know how expensive it will be. This is the phase 1 trial, 6 individuals, but really exciting. And as you can see with higher doses, the ability to knock out this gene completely, and this goes out to a year of therapy, looks quite striking. So stay tuned on that. So here are my take-home points. ATTR, transthyretin amyloid, is the most common form of cardiac amyloid. There's 2 distinct types, the wild type and the hereditary forms. Around 1 in 6 people, I didn't go into this in too much detail, but around 1 in 6 people with HFpEF has TTR amyloid, predominantly the wild type. Those with severe aortic stenosis, particularly low flow, low gradient aortic stenosis, often have TTR amyloid in their hearts. And there's lots of new upcoming therapies that are safe and effective for neuropathy and cardiomyopathy. Thank you.